And what I want to do for our next speaker is, be present in your body, like recognize who you are, and maybe your back, maybe your legs. Can you go ahead and shake your legs out, kind of get the blood flowing? Yep, there you go, even stood up, I like that. So guys, I did that on purpose because next up, we have Dr. Trisha Roy, Vascular Surgeon and Scientist for Houston Methodist. Let's give her a round of applause, y'all.
So thanks so much for having me. It's such a pleasure to be here and just really an honor to share some of our insights from the vascular surgery world. But also, we do want to learn from your toolkit. I noticed that Dr. Lumsden updated the quote. It said, the other guy's toolkit, and now it's like the other person's toolkit. So we're advancing in more ways than one. But I am a vascular surgeon. I deal with the blood vessels outside of the heart, but specifically I focus on the legs. And so what we're talking about is blockages in the blood vessels in the leg. And I was covering the vascular service this weekend. This is a growing epidemic. Patient after patient after patient, I'm seeing that they don't have enough blood flow to the leg. And what happens is your legs get starved of oxygen, you get excruciating pain, wounds, and ultimately can develop such severe infections that you're requiring amputation. So this weekend, like many weekends, I had to have a conversation with the patient saying, we tried again and again, we failed, and now you're gonna have to lose your leg above the knee. It's devastating. So right now, our big problem, we don't have effective ways to durably restore blood flow. And this is what our toolkit looks like, okay? So we can do this in a minimally invasive way where we do a needle poke in the groin and we navigate wires or devices inside the blood vessels under X-ray guidance. So this is where we're radiating ourselves doing this. And then the other way is to just reroute the blood flow altogether. We do a big cut in the leg. We hand sew the blood vessel above and below the blockage to reroute blood around that. We have much older, frail patients, and so most of us try this minimally invasive approach first. And we've had a lot of technologic advances, okay? So we can do lithotripsy where we break up the calcium in the vessel wall. We can drill it out, laser it out. We have different types of cutting balloons, but despite all that, nothing has actually worked better than just ballooning things open, and that does not work well. Not only that, these technologies have been related to potentially making our patients worse. Higher amputation rates, and the New York Times has picked this up, and we have a lot of focus on this right now, and rightfully so. Our patients deserve better. So why is this so hard? Why don't we have something better than that? One of the problems is that we are all unique. Your chronologic age is very different than your physiologic age, and you are only as old as your arteries are. And that's affected by your genetics, by a lifetime of habits, smoking, exercise, but also your access to care. If you have access to preventative health care, it makes a difference. Not only that, the blockages themselves, they vary a lot over those decades of that developing. So you can have these calcified rocks, you can have the calcium lining the blood vessel, turning it into a lead pipe. You can have fibrotic lesions that you can't see very well. And then even when it's soft or friable things that we can get through or open easily, then those little bits can break off and actually dislodge and go into the downstream blood vessels and make things worse. So each of these kind of plaques actually have their own challenges and their own devices that are going to be effective in it, but right now we can't tell them apart. So that's what my lab is devoted to. I'm a materials engineer by background, and I want to look at how do the material properties of these blockages affect the challenges that we're facing. Right now, our current approach, I mentioned the angiogram, so that's where we squirt some dye in the blood vessel. We just see where the open areas are under X-ray. You can imagine you're not actually looking at the blockage themselves. You have no idea what it's made out of. CT scans have been a challenge, especially in the small 2 millimeter vessels below the knee, because you have these beam hardening artifacts, blooming of the calcium. Ultrasound, also a challenge. You know, the calcium causes acoustic shadowing. We can't see the flow beyond that. We think it's blocked. It may or may not be. So our work is about magnetic resonance histology, using MRI methods to evaluate the blood, look at the plaque type, and use that to make informed decision about what type of treatment to provide for our patients. So this is an example of one of our blood vessels. So this is the blood vessel behind the knee. And you can see that there's a lot of variation within the plaque itself. So this is 0.2 micron, 200 micron isotropic resolution. We have a 7 Tesla MRI. It's a clinical scanner, but you can see that it varies a lot along the length of it, and it's a very heterogeneous plaque. So the other problem is these are very, very delicate blood vessels, okay? So when we're blasting these open, we're damaging this inner lining of the blood vessel, the endothelium, and that creates the sticky surface. Now when the blood passes by, it actually sticks and can clog up that way. You can see that when we're ballooning up these rigid vessels, there's a lot of force that we're putting on. We disrupt the plaques completely, and the vessel walls respond by becoming thicker with more smooth muscle proliferation. And all of this damage that we're doing, we have no idea. We can't see it, because on X-ray, none of this shows. So we don't know what we're doing to the blood vessel wall. And that's kind of why we have this device development lab, where we want to see how the different devices are affecting our vessel wall. What we do is we image patients with our 7 Tesla MRI. We do an amputation if they don't have enough blood flow. And then we perform our interventions in our lab exactly as I do in the operating room. And then we can harvest those blood vessels, look at it under a microscope, and really understand what different devices do in different types of blockages. But there's other things that we still really need. So one issue is that we've long assumed that blood vessels in the leg are just like the heart, and you get heart attacks of the legs where these fatty plaques just rupture, and that's why it blocks off. We're learning that that's not the case. It's a very different type of blood vessel, and the issue is this problem with compliance. If you don't have the ability to accommodate pulsatile flow, you get very, very high resistance flow, friction, and we get damage to the vessel wall that way. So we want to understand the flow dynamics in small, small vessels of the leg. In my MRI world, we do 4D flow. That's been done in the aorta, but in small vessels in the leg, that's very challenging. These are just kind of showing you different types. But the other thing is we need new techniques, right? So we need to be able to get through these rock-hard lesions. And one of the problems is you don't actually know where you are in the vessel wall. So you can be in between the layers of the vessel wall. And if you have a drill that's really effective at getting through a rock-hard lesion, it's also going to be very effective at damaging the vessel completely, and you kind of perforate, and that's a big problem. So how do we get through these lesions and actually do that in a safe way? And if you do get through the lesions, how do we open them up? Right now we're just blasting it open with a balloon. We're damaging that inner wall. So how do we do that without damaging the vessel wall? So my lab has been really focused on how are we going to reduce our failure with MRI histology techniques, understanding the pathophysiology of the disease, device performance and safety, and clinical studies. But ultimately, my ask and what I think we really need is some of the innovative techniques in your other fields so that we have better imaging techniques, analysis, different devices to open up these blood vessels, and hoping to learn from your toolkits what we can do to serve our patients better. Thank you.
Excellent, excellent. I got this one.